So we'll talk about imaging to guide transcatheter procedures. I have no conflicts of interest or disclosures at this time. I'm paid equally by all companies. So the last 2 decades have really witnessed an absolute explosion of transcatheter interventions, and they've been catalyzed by several key factors. Number one, and we've seen abundantly in this session, advances in non-invasive imaging techniques. Echo, MRI, CT, I mean, those were just unbelievable pictures. There really is an imaging revolution. And the imaging revolution is coming into the cath lab as well. So number one, advances in non-invasive imaging. We know what we're looking at. We know what we're doing when we go into the cath lab, as opposed to using the catheterization laboratory as a diagnostic laboratory, as it was, and really the way I learned catheterization under Dr. Michael Criley, who I'm happy to say is in the audience, is hemodynamic catheterization. Well, that has unfortunately become a bit of a lost art because of all of these non-invasive imaging techniques. It's still very important to know how to do that, but most of the time when we're going to the cath lab now, we're going for some sort of interventional purpose as opposed to pure diagnostics. Number two, advancements in catheter design, wire design. They've allowed physicians to easily engage unusually located structures and tortuous vessels. Number three, new materials, things like materials like nitinol, which is a shape memory alloy, have allowed us to improve the design of stents and devices that go up to 3.8 centimeters in diameter can now be crimped into a catheter and put in through a femoral vein or a femoral artery. Advances in fluoroscopic imaging quality within the cath lab. Imaging in the cath lab like intracardiac echo and TEE, and some of the other imaging modalities that I'll talk about today, such as using overlay imaging and rotational angiography in the cath lab. And then most recently, hybrid procedures and transcatheter valve repairs, and you're going to hear about all this sort of stuff more tomorrow. So intraprocedural imaging in congenital heart disease, and specifically in the cath lab, really started in the 1950s and has been widely utilized since that time. There is no hospital, frankly, of any size that doesn't have at least some fluoroscopic imaging capability in this country, and really in most places. I mean, we go on medical missions to Peru with Dr. Young, and we go to local hospitals there where they have cath labs, and it's just widely used at this point. Advances in echo, specifically Trans-Esophageal Echo, and to a certain extent intracardiac echo, have also led to the wide use of these techniques to guide procedures. And closing an ASD these days, you're not going to do it without intracardiac echo or transesophageal echo. Rotational angiography with 3D reconstruction capability, which is now commercially available over the last few years, and I'm happy to say we've been able to install those systems at UCLA and use them, and I'll show you how those work. But that's the next level. Those beautiful CT images we can now actually import into the cath lab and overlay them on the fluoroscopy screen and do a case live while we have the model of the complex heart sitting there. So again, makes our procedures safer and allows us to do more things. Here's an example of fluoroscopy for ASD closure. So this is the classic AP lateral view after implantation of an Amplatzer device. This is a huge device. You can see what we're doing here. We're using fluoroscopy, looking at the device in 2 views, AP and lateral, but there's something here in this patient's esophagus, and that is the transesophageal echo probe. Absolutely key to guiding these interventions. I personally, and different congenital interventionalists will use different techniques. I personally use transesophageal echo widely for these purposes as opposed to just intracardiac echo. I use intracardiac echo for simple things like PFOs or very small ASDs or occasionally closing Fontan fenestrations, but I really like the quality of transesophageal echo. And I'm happy to say that we have a complement of fantastic imagers from Dr. Lin to Dr. Reardon, Dr. Pilutla, among others, our pediatric cardiology colleagues who come into the cath lab and help us with this. And this is the same patient that I showed you previously, the fluoroscopic image of. And what we're looking here is, secundum type ASD closed with an Amplatzer septal occluder. This is the 2D transesophageal echo. Right atrium, right ventricle. See, there's a little bubble study here. I don't even know if we meant to do that. I think somebody just flushed a line. Left atrium, left atrium, left ventricle. And you can see here that, you know, at least with the contrast that is in the right atrium, we don't see any of it crossing over. This is a three-dimensional reconstruction of that device, looking at it on FOSS. And you can say, you know, how useful really is this? Well, I'll be honest with you, really good 2D imaging in orthogonal planes is as good, in my opinion, as 3D imaging for most things. However, you get some idea of the shape of the ASD, the way the ASD changes its size, and ASDs are actually very dynamic structures. In systole and diastole helps you size a device nicely, and then shows you how the device is straddling around the root of the aorta here. You can see here that there's a trileaflet aortic valve here with some mild aortic stenosis. Here's an example of a transesophageal echo in a patient who was in their 80s, actually I got called to the VA to help out with this case, who was found to have about a 2-centimeter atrial septal defect. But this man had diabetes, hypertension, atrial fibrillation, was volume overloaded, had pulmonary hypertension. His left atrial pressure was about, directly measured, was about 16 millimeters mercury. So one of my worries with a patient like this is, and you know, he had a net shunt of about 1.7, 1.8 to 1. QP to QS ratio. So certainly legitimate to try to close the atrial septal defect, but one of the worries here is that if you close this atrial septal defect in somebody with a very non-compliant left ventricle, which an octogenarian with all those risk factors, and he's a veteran and smoked in addition to that, and had coronary disease, in addition to all those risk factors, you know, you have to really think about what's going to happen to that left ventricular filling pressure when you take away this pop-off. And so the technique that I use here, which is guided in many ways by the transesophageal echo, but also by the application of hemodynamic data, measuring left atrial pressure either directly through the end hole of the balloon catheter or measuring wedge pressure and estimating left atrial pressure, is to balloon occlude these ASDs and see what happens to the filling pressure in the left ventricle. And if the filling pressure, like in this gentleman, shoots up, in this case, we closed the ASD with the balloon, and his wedge pressure went from 17, 18 up to 26 millimeters mercury. Big V waves. So you know his left atrial pressure really shot up. So what I did with this is I took the device and I fenestrated it. And it's a very refined technique of essentially stabbing the device with a dilator, but essentially creating a hole that over time may close. But you can see that the fenestration here is relatively large. There's flow here through this fenestration. Unfortunately, let's see if this will play. Yeah, couldn't get it to play. But be that as it may, the left atrial pressure was no higher after the ASD closure with the fenestration of the device. And this is now a technique that's been published and used by various groups. Some people just put holes in the device. Some people stent the device open. But it's really nice to be able to visualize it this well live in the cath lab with one of our colleagues doing the transesophageal echo. We also use intracardiac echo for predominantly ASD, PFO evaluation. But you know, I had a case last week of a young woman with, actually about 2 weeks ago, with a ruptured sinus of Valsalva aneurysm, who I took to the cath lab to do a hemodynamic catheterization on before we sent her to surgery. And while we were there, I put up an intracardiac echo probe, and it's amazing what you can actually see. Looking up at the aortic valve, putting the probe into the right ventricle, looking up at the pulmonary valve, but your mind has to switch around a little bit because we're looking typically from the esophagus through the left atrium to the right side. Now you've shifted everything around, and you don't have the same multiplanar capacity as you do with transesophageal echo. So it's a growing area. I use it very widely in my practice, but it has certain limitations. And when I don't see well with intracardiac echo, I just go with TEE. So, and usually call one of my colleagues, and they're very helpful with that. Here's an example of how TEE can be used for Vsd closure, identifying a perimembranous Vsd here, partially closed by the septal leaflet of the tricuspid valve. We can see that there's flow here. And then when we take this patient to the cath lab, we use Cine Angiography in biplane mode. It's very important to do congenital catheterizations in a biplane lab, and that's how we were taught. And however, I will tell you that more recently with the application of rotational angiography, my practice has changed some, where I will do a lot more cases in a single plane lab if I can do a nice rotational angiogram and then come up with an optimal working view. But ideally, you want to have a biplane lab. Here's the VSD right here, and you see a left to right shunt. And then, using Cine Angiography, or in this case, fluoroscopy actually, what we do is guide a wire across the VSD with an end-hole catheter like a JR3 or JR4, put the wire up into the pulmonary artery and then snare the wire from the venous side to create a wire rail through the heart. It's very important in this case not to actually floss the heart. What you don't want to do is have the wire exposed as it's going through the ventricular septum. You'll cause heart block that way. So you want to be sure that the wire is covered with catheters, and you use sort of a kissing catheter technique where as you pull one catheter back, you have to advance the other one up. And that gives you a strong enough railroad, that wire rail, to actually be able to put up a large sheath or a guide catheter and then deploy one of these nickel titanium alloy devices. And then the TE is on the entire time, and we have it on a separate screen. So what I'm doing is I'm looking at the fluoroscopic imaging, and I'm also looking at the TEE, and I'm talking to my colleague who's performing the Trans-Esophageal Echo and saying, well, you know, I don't see that this well. Can you change the orientation, et cetera? And then, you know, there's nothing that says you can't use transthoracic echo in the cath lab. I mean, you know, sometimes transthoracic echo is a great way to see things. So, you know, we'll image from above, from below, intracardiac. And you have to be creative in congenital heart disease. That's the thing, is, you know, you can learn the basics, but in the end, if you're going to treat complex congenital heart disease, you have to be prepared for something you've never seen before, something without a predictable pattern, like the case that Dr. Ranella showed, where they had baffled the SVC to the left atrium. You know, these things you have to be prepared for. But here's a transthoracic echo in the cath lab that shows that the device is very well placed. Now, I want to focus a little bit on 3D MRI and CTA image overlay, and I'm going to show you some examples of that. This is relatively new technology. There are a very limited number of case reports and case series in cardiology. These techniques, though, are increasingly studied and being applied in various invasive vascular procedures, including electrophysiology. The EP folks have really led the way with some of this. Interventional radiology procedures like chemoembolization of tumors, peripheral vascular interventions, great for that, coronary imaging and interventions, but the main limitation there is motion. But I will show you that we have some very nice ways of actually imaging the coronaries using these techniques. Valvular and structural interventions, I'll show you implantation of a melody valve using one of these techniques. And, you know, congenital heart disease, which is really the focus of this entire talk. But really, there's just a handful of case reports and small case series in congenital heart disease using these techniques. There are currently available systems from essentially most of the major makers of imaging systems. The currently available systems provide, and all of them provide this to some capacity, 3D visualization, including a back view display where you can take an image and look at it from behind. Cut plane modes, you can fuse 3D models onto fluoroscopic images. Unfortunately, the technology hasn't really been developed yet to do it in the lateral plane, which is why I said to you, oh, now I'm working more in a single plane lab. Well, it's because I can overlay in the single plane lab. I can't do that yet in the biplane lab, but they promise us that that's coming, and we're going to get that hopefully by the end of the year. Rotational angiography, CT or MR 3D models, they can all do that. Registration of 3D overlay on the 2D fluoroscopy with ECG gating, motion compensation, respiratory compensation, and I'll show you some examples of that. And then, you know, the image should follow the table. As you pan down, as you pan up, the image should move. So you don't have to work in a static mode. For EP, it'll give you an ablation line display, and there are point marking capabilities. And it should be fully integrated at the bedside. If you have to scrub out and go back and sit down and play around and then scrub back in to do what, then that's going to be really tough. So you really need technologists who are on board with you. It takes a lot of work. When I do this, I actually have to spend probably an extra half hour before the case, cropping and cutting and doing all of these things, and then overlaying the images. The rotational angiography is a lot more straightforward, but you know, still some complexities there. And then the lateral plane, and that's a major limitation for those of us that are used to working in a biplane lab, but hopefully that will be taken care of soon. This is an example of what the EP folks are doing. This is a CT overlay of the left atrium, and they've colorized it. Here's the superior vena cava, which is going to be coming down. Sort of, they showed it running behind the left atrium, but it's actually running in front of the left atrium. Coronary sinus here, and you can see various electrophysiologic catheters in here. There's a basket catheter in a pulmonary vein. So we take that, and then we do respiratory synchronization, so now it actually moves with the diaphragm, and you have to synchronize to some structure within the heart, like one of these catheters. But you know, it's still pretty choppy, and that's what it looks like now. But you know as well as I do, in the next 5 years, this is going to get a lot better. So we're still early on with this, but moving ahead. This is an example of a pigtail catheter that's been put into the left atrium via transseptal puncture, and then an injection's been done in the left atrium, contrast injection, when the patient received adenosine. So the heart is standing still. If you have a lot of motion, you're not going to see anything. So you have to have the heart still. You either have to pace really fast, and we typically will put a transvenous pacing wire and pace at 180 beats per minute to do the rotational angio. It's a 210-degree spin that takes 5 seconds. So something like 12 cc's per second for a total of 60 cc's of contrast, timed with no respiration and with rapid pacing. It's very tough to do this in the awake patient, frankly. Right? Hey, you're going to feel really dizzy and start passing out, but hold your breath, and it's going to take 5 seconds. You know, so you really need to use this in the patient under anesthesia. But here's an example of what you can do with the left atrium. You crop out the mitral valve, and then you can look at the pulmonary veins, look at the appendage, and plan your intervention accordingly. You can do fly-through modes within the left atrium, looking at the pulmonary veins. There's the left atrial appendage, there's the mitral valve, and you're sort of looking at these other pulmonary veins, look at the distances, look at the ostia, if there's a question about ostial stenosis, for stenting. You can do fly-throughs through the heart. This is an example of somebody who received adenosine and had simultaneous injections in an upper and a lower extremity, and it's essentially a CAT scan. It's a cone beam CT. In a way, it's not as good as Dr. Moriarty's multi-detector, you know, Star Wars spinning thing that he showed. But you know, it's a slow spin, but it's pretty good for us in the cath lab, and it's a heck of a lot better than what we used to have. And then you can take this and just do a 3D reconstruction of the right side of the heart. Look at the pulmonary arteries. I mean, you know, for something like thromboembolic disease, you can imagine how useful this could be. And you can do fly-through modes within the heart, and this is going out of the RVOT. You're in the main pulmonary artery here, and then you're going to look at the branch PAs. If you're considering how you're going to stent them, what the distance is from one PA to the other. You know, here's an example of somebody that was taken to the cath lab actually by Dr. Levy after the patient came to see him and had a really high residual gradient after a coarctation stent done elsewhere. So he took them to the cath lab to see what was going on. The stent looked a little bit low, and did a rotational angio with the pigtail here in the aortic arch, and that 5-second spin, and then reconstructed the aorta. What's nice is when you actually do aortic imaging, or you do imaging in the superior vena cava, for example, for a Glenn shunt, is you really don't have to pace very much, because contrast will hang around there a little bit longer. I prefer to myself to get the cleanest image. But what you note here is that there's stenosis all the way up here, but the stent is down here. So this stent has actually embolized. And more than that, there's actually an aneurysm here of the aorta. You can see it right there and extends right outside the borders of the stent. So you can do a cross-sectional analysis of this, and we can pretend we're radiologists now and sort of look through things in the axial plane in the cath lab. And we go up and we see the stent here, and it looks very well opposed. And as we go higher up, oh, what's that? We start seeing this actually is a pseudoaneurysm outside the borders of this stent, and then we can delineate just how far it goes up. And we can also, and this is a little bit gimmicky, fly up the stent. Here's the catheter, riding up the catheter, and then we're looking at the inside of the aorta. There's the stent border, there's the aneurysm, and then we keep going up into the aortic arch. It's nice when you're planning interventions and deciding where you want to land things and how far you need to go. Here's an example of a very complex arch, very complex coarctation, just distal to the left subclavian here with a highly aneurysmal descending aorta and just a, an aorta that's essentially kinked on itself. And then here's the result after stenting. And we can really get a nice appreciation for what our stent is doing and whether we're in any way compromising the integrity of the vessel. Sorry, I couldn't get this to play, but these are two available aortic valves. One is FDA approved. This is the Edwards Sapien valve. Here's the core valve still in clinical trials, but essentially being implanted in the aortic position. And you can see overlaying the aorta here from CT angiography can be very helpful in deciding exactly where the coronaries are and where you need to land your aortic valve at the time of intervention. This is a case that we did a few months ago of a young man with a homograft from the right ventricle to the pulmonary artery. He has tetralogy of Fallot, and he has severe pulmonary regurgitation. This is an injection in the main pulmonary artery above the level of the valve. So you can see the right pulmonary artery nicely, the left pulmonary artery is nicely seen. You can see the area of narrowing of the homograft. This patient has both stenosis as well as regurgitation. And you can see reflux of contrast back into the right ventricle. This is done at 180 beats per minute with that rotational spin that I told you about with the 3D reconstruction. But the way this really is very nice is it gives you optimal working views. So you can select the view and you can say, you know what, I want my II to be 45 LAO, 20 cranial, that's the best way I'm going to image this, and then I'm going to work on this in this view, and I'm going to overlay this image on that. We can also do coronary compression testing. This is an example of the same technique in this same patient. This is actually all the same patient. This is just a little bit later in the case where we have put a large 25 millimeter high pressure balloon through this narrowed homograft here. And we're inflating it in the homograft, but at the same time, we're injecting contrast in the aortic root while we're pacing at 180 beats per minute, and then we do the rotational angiogram. And what we're looking for here is coronary compression. We want to make sure that our balloon is not compressing the left main coronary artery or an anomalous right coronary artery before we go putting a melody valve in here and crushing the patient's coronary artery and causing them to have a major myocardial infarction. So this shows it beautifully. I mean, I would, bet anybody that you cannot get much better coronary imaging than that with any technique. Yes, it took 60 cc's and 5 seconds of, and God knows how much radiation, but you get beautiful images. This is after we've implanted a melody valve in this same patient. Note that we were able to land the melody perfectly here without obstructing the right pulmonary artery. We really didn't have much real estate to work with here, so you had to land it just so. This technology allowed us to do just that. We were able to land the melody perfectly, and now we have injected contrast into the PA, showing that there's really no PR left. This is just scatter artifact here from the stent. Then we can use this sort of MIP imaging to look at the integrity of the stent. Stent fractures can occur in a large percentage of these patients, if you're putting these into homografts, if they're calcified, if the homografts are right behind the sternum and compressed and elliptical. So it's important for us to look for that, so we can look at the integrity of the stent that way. And then here is, I think, the most exciting application of this at this point, which is taking the 3D overlay. This is in a patient with tetralogy of Fallot, a dilated aortic root, and a homograft that's highly dysfunctional from the RV to the PA. And this is from an MRI. This is an MR angiogram that was done 6 or 8 months before this procedure. But we were able to import it in, crop it, and then register it to our fluoroscopic image and go ahead and do angiography, and we match it perfectly there. And then we go ahead and deploy our Melody valve with the 3D ghost in the background. And that way we make sure that we are not in any way impinging on the branch pulmonary arteries, and we're not hanging too far out into the RVOT. So nice stuff, and you notice here that in all of these, patients going 180 beats per minute here. So be prepared for a little ventricular tachycardia sometimes in a tetralogy patient. If you don't have respiratory suspension, if the patient is breathing, this was a patient that we had put multiple stents in her superior vena cava after a botched anomalous pulmonary vein repair surgery, and her SVC was quite narrowed, so we put multiple stents in there, and we were trying to image these stents and look for any fractures, and this is the rotation, and then here's what it looks like on 3D reconstruction because she didn't hold her breath. Useless. So it's kind of a waste if somebody cannot hold their breath. This is a Fontan, an extracardiac Fontan. This was a very interesting case because I found a gradient across this patient's Fontan, about a 2 millimeter mercury gradient, and I couldn't find any stenosis by angiography. So we did one of these rotational angiograms, and we had a 3D TEE probe in, and this is a MIP mode, and I can't appreciate any stenosis within the Fontan. So then we do our 3D TEE, and I'm looking at it here, and this looks pretty good. There's the extracardiac conduit. Here's the conduit, more on FOS. Here's the conduit laid out. You can see here there's an AV valve right here. It's opening and closing nicely. And in all of these views, here's where the conduit enters the branch pulmonary arteries. It's looking okay. Until we start to do this rotational angiogram, and then we start to notice that there's a kink right there in the extracardiac conduit. Would have never seen this on biplane imaging. Really, the only way I could have seen this is with rotational angiography. Even 3D reconstruction, frankly, wouldn't have shown it to me well. I would have really had to guess that, oh, there is a little impingement here. Now, luckily, her pressures were okay, and we didn't have to intervene on this, but these kinds of subtle things we previously just did not pick up. So what are the next steps? Triple overlay technique with co-registration of pre-procedural MRI CT, intra-procedural 3D rotational angiography, and then live fluoroscopy, all with 3D manipulation. And then there are studies in progress to even add 3D echo to that, so that you can have now a live echocardiographic image that you can switch back and forth to that's overlaid on your fluoroscopy screen. ECG synchronization for all of these dynamic cardiac overlays, the ability to do intravascular roadmaps, and then really the holy grail here is going to be live MRI-guided interventions. I mean, that's going to be where this goes, where we don't have to use all this radiation, and we can use MR-friendly catheters and do our interventions. So conclusions. Fluoroscopy and cine angiography continue to be essential and are really the backbone of imaging in the cath lab. Advances in 2D and 3D echo have resulted in really just very widespread use of these technologies, and they're invaluable. You're not going to close some of these defects without having some sort of echocardiographic imaging. CT, MR, overlay in the cath lab with the 3D reconstructions that I showed you, that really is for something like complex congenital heart disease, I think will be invaluable. There are commercially available systems now that will allow you to do that, but we still have a little bit of a paucity of literature here on support this assertion, but my assertion is that the potential benefits of these 3D techniques in the cath lab are just immense. Improved image quality, improved interventional guidance, the potential for lower radiation, and improved patient safety, not to mention the ability to teach a very complex field to our colleagues and actually show them images that make some sense. So I thank you very much.